We are live. Thank you very much, everybody, for coming to this event. Today, on the last event of the day, we are going to talk about the problem with vaccine nationalism and how does that come to be the norm in this pandemic, and whether there is something new about it or just the expression of something that has existed long ago and showing itself today. We have a very, we're very lucky to have our panel. We have with us three panelists who I will introduce very briefly, and they will kindly feel free to expand on their background if they want. First, we have Micah Voss, who is the Managing Director of the Planetary Health Alliance. We have with us Marlies Richter, who works from out of Cape Town, has been the Director of Policy in Sonke. And we have Ashal Brabala, who is a long-time advocate author and has worked on intellectual property and access to medicines for a very long time. So we have, as you well know, gone through all the stages of grief in this pandemic. The first one in terms of policy or rhetoric is one where we have been told that the pandemic is the great equalizer. This is the early days before we had any much hope of having a solution or a vaccine. Much of the rhetoric was about how all of us are in the same boat. Now, let aside that some of them were on actual boats in the ocean that they could afford to separate themselves socially from everybody else. But it turns out very quickly that we are not on the same boat. The ability to socially distance, to keep protected and so on has been largely confined to people who could work from home, those who were essential workers or couldn't afford to live without being in places that where the manual work or otherwise takes them, haven't been as lucky. The pandemic turned out to be a great separator rather than a great equalizer. This has become much more of a problem when the possibility of vaccines appeared, when the solutions that cost money started becoming apparent. And of course, again, the issues that the second stage of our grief about the pandemic has been that when we were told that the vaccine is a global public good and that we should rest assured that the pandemic is not finished anywhere until it is finished everywhere. The rhetoric about the global public good and about our collective ability to rid ourselves from the modern day plague crumbled very fast when both the vaccine was becoming reality and the impossibility of achieving equality in the distribution of the vaccine became apparent. The global public good started becoming a very private good for only a very thin slice of humanity. To address that from a humanitarian perspective, as we stand in this Congress, we are going to look at it from the point of view of people that we serve, from people we care for, both on what has come to happen, whereby most of the countries of the North have near full coverage of vaccine, and most of the people who are already living in humanitarian crises or in situations of ill health, bad health services, crumbled health systems, and endemic diseases have to suffer the continuation of low coverage and the influences of that. Now, there are some arguments that have to be addressed head on. We have heard the expression vaccine apartheid repeatedly. This once came from Dr. Tedros, who's the general director of WHO. And for WHO, a member state-led organization, to say something that sharp and to talk about the great moral failure tells you something about the severity of the situation, because usually they talk is much milder and more diplomatic. We are in a situation where even a word as abhorrent as apartheid applies today, where people have no recourse to improve their lives, and where mechanisms that have been created in the name of achieving that health equity not only failed in doing it, and that has become an agreed fact, but have become part of making it impossible to achieve any direct direct way towards health equity in vaccines or in the recovery from the pandemic. Today, we're going to ask a few questions that aren't about who made the bad decision that made this thing fail or the other. We're going to dig a little deeper and ask what are the structural underlying causes that make it impossible for mechanism of equality through the current multilateral system to work, and how would humanitarian organizations be able to look at a situation where there's no way for them to serve people they aim to serve. I will start with the first round of questions, and I will start with Achal. And, you know, Achal, thank you for being here. We were told early on that, you know, we have the systems, we have the infrastructure, we have the ability to create a very rapid mechanism, in this case, COVAX, that would help us achieve equity. Now, it was not incredibly ambitious because it talked about 20% coverage in the countries that need it most, but even that is far from being the case today. The argument is not on whether COVAX failed. The argument today is on why are we in a system where it seems impossible for something like COVAX to have succeeded.
Tamam, thank you. And it's nice to be here. It's such a pleasure to talk to you, as always. Maybe we can start by describing what COVAX is for those in the audience who might not have heard this acronym. Those of us who are inside this, our head is filled with too many acronyms, honestly. The COVAX facility is a consortium of 3 organizations. In name, it's truly led by one of those 3 organizations, Gavi, which stood for something when it was founded 20 years ago, but is now known as Gavi, the Vaccines Alliance. And CEPI, which has an incredibly odd name, which I do have to spell out in full because it's so odd. It's the Coalition for Epidemic Preparedness Innovations. And the World Health Organization, which of course all of you know. CEPI is an organization that was designed to incentivize vaccine research. And so it was designed to work on the push side of the equation to create vaccines that we need. And Gavi was the pull side of the equation, which is to get those vaccines to some of the poorest countries on earth. The World Health Organization, of course, serves in COVAX, I should say, as a moral authority. So they are the organization, for instance, that set very early on in the pandemic a framework by which vaccines could be allocated around the world. Because when COVAX began forming and working in this pandemic really early on, so way back in 2020, they decided to function as a buying mechanism, not just for the 92 poor countries, which are by World Bank classifications low and lower middle income. Your head will spin with a number of definitions and classifications and acronyms. So I'm trying to make this as humanly intelligible as possible. COVAX decided not only to serve those 92 poor countries, but actually all countries, including what are called middle-income countries, upper middle-income countries, Latin America, in West Asia, what you call the Middle East, and in rich countries as well. So they wanted to serve the entire world. What they felt was that they'd be best suited to do this because then they could allocate those vaccines most equitably. Now, what happened since that time was first that rich countries didn't rely on COVAX to buy their own vaccines. As we all know now, they went and to a number of different bilateral deals with vaccine manufacturers, struck their own deals, received vaccine supplies way in excess of what they need, continue to do so, continue to hoard and occasionally waste those vaccine supplies. Middle-income countries, by and large, kept the scraps of what could be offered from Western manufacturers and instead turned to countries like China to receive bulk doses, like many of the countries in Latin America, as well as countries in West Asia. The lowest income countries in the world, of which I happen to live in, one, did what they've always done, which is manage without. India is an exception, of course. It's an anomaly. We house the single largest vaccine manufacturing company in the world. We house dozens of other companies who are making one kind of vaccine or another. There are several companies involved in COVID vaccine projects, and we're lucky because we can produce large quantities of vaccines. We're also in a difficult situation because the vaccines produced in India, in large part, were contracted to be sent to other low-income countries in the world, a facility that India suspended in March, not in March, but in March or April of this year, when we experienced a surge of cases just about the time that vaccines in India were being readied for export. So there was a first round of exports that happened between the end of January and early March. But by April, those gates had shut down. So even the countries in sub-Saharan Africa who were relying on India for vaccines, even those small doses that they were relying upon us for to get through COVAX, instead went to us, to my family, and to other people in this country. So it's a double-edged sword, and I sit here both as someone who lives in a poor country, but also a highly unequal poor country, which is in a position of privilege. Very few other countries in this list of 92 countries are in this position. South Africa is an upper middle income country and has vaccine manufacturing capacity, but it's not eligible directly for COVAX charity in the manner that the COVAX facility was designed. Now, of course, what has happened is that for the first 6 months of the pandemic, the COVAX facility excessively relied not just on vaccines from one country, but on vaccines from one company in one country. And that didn't work out well when those vaccine exports were suspended by that one country, which is us. There are 100 ways to dissect what went wrong with COVAX, but to lift this argument up a little bit and go back a little bit, we could have learned a lot from an experience that COVAX underwent over the last 15 years in its program to deliver vaccines against pneumonia, the pneumococcal conjugate vaccine, or PCV, which has a lot of really interesting lessons for the kind of model that COVAX believes in, supports, and in fact encourages. And in short, that model is the model of the biggest pharmaceutical industries in the world, which is that the massive amounts of state funding they receive from their states, whether it's the United States of America or Europe or Germany, are justified. That they are not only justified in taking this funding, but also funneling it into not just private profits, but monopoly control over the products, which are the fruit of that public funding, and that they are the ultimate authority to decide where doses should go and can go. This happened somewhat unseen with pneumonia over the last 15 years. Gavi's business model for a vaccine that was widely used in the United States and Europe, but not used to the hysterical extent of need that we have now for COVID vaccines, allowed Gavi to say to two companies, Pfizer and GlaxoSmithKline or GSK, that they could do everything they wanted. They could sell these vaccines for as much as they liked in Europe and in the United States. But what Gavi would like is a few extra doses at a steep discount, in exchange for which Gavi would ship those doses to poor countries through funding they receive from rich countries at a subsidized price. So poor countries would still pay some amount of money to get these doses, and that they would take care of a range of different functions for Pfizer and GSK. They would handle regulation issues, registration issues, insurance issues, and a range of other problems. So finally, it was a great deal for Pfizer and GSK, and of course they consented to it. They were still being paid good money for these vaccines, and they had absolutely no distribution costs or marketing costs or any other hassles around them. Gavi effectively took care of that. But it came at a cost, and the cost that it came at was that they supplied far less vaccines than they could have to the world, as a result of which there were tens of thousands of children who still die of pneumonia across the developing world. So it did not by any means solve the problem, it helped. And secondly, what it did was to entrench the idea that pneumonia vaccines could only come from these two companies located in the United Kingdom and in the United States. And the best way to illustrate how this program went awry is to know that 2 months before the program shut down at the start of the pandemic in 2020, a company in India, the Serum Institute, produced a very cheaply available PCV vaccine, a pneumococcal conjugate vaccine, at a tiny fraction of the cost that could do the job of the Pfizer and the GSK vaccines. It took them 12 years to do that without any assistance from any contractor or philanthropic organization anywhere in the world. Had they been encouraged to do so a little early, towards the late aughts, when Gavi began its pneumonia work, they would have been able to complete this project much sooner, bring a cheap southern manufactured vaccine to the market much quicker, have it out in the world in far greater quantities than Gavi was ever able to provide, right? But of course, Gavi did not see that opportunity, did not take advantage of it, in fact, did not encourage it in any way whatsoever.
What I will come back to, Achal, sorry,
Yeah.
just to keep
Yes.
us within time.
Yes.
So what we're saying is that we have a system that whereby a subsidized vaccine, subsidies are going to companies that are richer and that are using the system, both wanting to commodify vaccines and make a market out of it, and at the same time use subsidies and protections from taxpayer money, from money that was supposed to improve coverage, that ended up doing the opposite. Let me just go to Marlies for a minute. And Marlies, you're in a position whereby you're looking at this from South Africa. And as Achal mentioned, this is a middle-income country that has certain privileges, but that has seen the difficulties coming from this hyper-commodifying of the vaccine in COVID-19, the discrimination in access, both in terms of South African access versus other countries, but also internally. How do you see that? Why did South Africa end up in a position where their recourse is to ask for intellectual property to go away in the vaccine waiver? Can you give us a view from there, please?
Sure. Thanks, Taman. And greetings from Cape Town in South Africa. Taman, I think yours is a very interesting question, and I am very aware that the leadership shown by India and South Africa in co-sponsoring the TRIPS waiver in October 2020 are important indications, I think, of some of the lessons we learned in the HIV pandemic. Achal talked about some of the difficulties around intellectual property and other diseases. And I think in South Africa specifically, the lessons we learned from AIDS denialism to the exorbitant cost of antiretrovirals when we had millions of people in South Africa dying from opportunistic infections from HIV. And I think that the lessons that we learned through the public advocacy, the mobilization, the collaboration between activists, between academics, international activists, in pushing for pharmaceutical companies to push back against some of the threats that they use. And I think the Pharmaceutical Manufacturing Association case in South Africa was particularly instructive, where our government tried to change some of the patent laws to make some of the medications more accessible, and that this legislation was challenged by the pharmaceutical industry with backing from the US government, and by creative partnerships through the Treatment Action Campaign, the AIDS Law Project, and many international partners, we were able to show that corporate greed was trumping the lives of Black and brown people, especially in the global South. And that case was eventually withdrawn, and we know that now South Africa has one of the biggest antiretroviral programs in the world. So I think that the lessons learned through HIV and AIDS, and the grappling of domestic legislation with some of the international and foreign law provisions around TRIPS, the pushing for the Doha Declaration, were all components that activated many people within our government to push for the TRIPS waiver, and that I think has been inspirational, but also I think, as mentioned before, quite disheartening that we know that the TRIPS waiver has not been passed and that there are countries blocking it. So I think I'm going to stop there.
Thank you very much, Marlies. What is emerging now, and I do not want to necessarily go into the technicalities, but what is emerging is a couple of threads that have been talked about, at least in humanitarian circles, and I'm here trying to separate it from the technical access and legal conversation, and make it more relevant in a humanitarian world, whereby those are rarely accessed in this sense. We have a situation where we have lessons from the past. I say lessons learned, although I would contest that they are variably learned by different actors, because I've heard Winnie Byanyima, who's the executive director of UNAIDS, recently reminding an audience that the lessons of HIV, the waiting until millions of people who died unnecessarily in the interest of protecting the corporate profit, hasn't been learned. And the question was, are we going to wait until others are sacrificed unnecessarily? And this is one of the elements that I believe links it to humanitarian action. Is maybe the discussion about trade is not directly a humanitarian issue, but the sacrificing of people's lives unnecessarily is a humanitarian crisis in itself. And this is where we are stuck in a place where the actors are outside our direct sort of humanitarian traditional. We're not here negotiating with a checkpoint or a militia, or in the most reductive, I may say, way of access to humanitarian situations or to patients. Or there, we are dealing with much larger actors in a situation that seems to have many justifications. And in going to Micah, the justifications here are not coming from guys in fatigues and guns blocking a road. It's coming from people in ministerial suits and sitting in justifying their positions very eloquently. The countries, many of the rich countries that have blocked many of the actions, whether TRIPS waiver or others, are justifying their position as if they are doing the most sincere and honest thing to help everybody. And now we are in a situation where just yesterday, Gordon Brown, the ex-Prime Minister of Britain, is saying that the moral position is to airlift nearly expired vaccines to poor countries. The discussion is not what sort of system puts us in a place where there are millions of doses of near expired vaccines that will be thrown away while people die from. Is should we airlift them or not airlift them so we'd give poor people nearly unusable vaccines? How are we sitting and listening to those people and believing them now?
By getting very, very angry in the first place. First of all, thank you for having me, and let me explain why I'm here maybe, because I just switched to a new position working on planetary health, but I have been working the past 4.5 years for the German Institute for Security and International Affairs, which is Berlin's largest think tank, and I headed there the Global Health Governance Research Team, and the past COVID-19 months I worked only on COVID-19 and also on vaccine distribution. So I would say the situation we have is not surprising because, as we said, we didn't learn the lessons learned from past outbreaks and from past pandemics, basically H1N1, Ebola. It all came with a big warning: this will happen again. So solidarity was crumbling from the very beginning, even before the first person got infected in the region of Wuhan. And when we look at the literature and we don't have to look so far away. We knew that maldistribution of vaccine or COVID products in general would happen again. When the talks of a vaccine as a global public good began, rich countries have already secured doses for their population and leaving the market almost empty. So when the talk of solidarity began from high-income countries, the market was already almost empty. And COVAX was created after first doses got secured by rich countries. So this leaves me with my conclusion already that we were not prepared as a global community, and we knew that this would happen. And at the same time, maybe we can further discuss this. I don't see big changes now happening that we will prevent the same situation we're in right now from happening in the next pandemic. So it's good to have this conversation that we have right now, but it seems like COVID-19 is not bad enough to really shake the system and really make changes here. I want to dive in a little bit on the narrative of global public goods and who pushed the narrative. Here in Germany, it was our federal president, Herr Steinmeier, which is usually not a part or not part in global health policy making. But in this crisis, he wrote an op-ed for the Financial Times, I think together with the heads of state of Jordan, Singapore, Ethiopia, and Ecuador, heading, "We need a global alliance to fight the pandemic," in April 2020, and also coming up with this narrative of global public goods. So it comes from the heads of state of these random group of countries that are usually not very involved in global health policy making. At the same time, also the narrative came from the EU level, from Ursula von der Leyen, stepping in the vacuum of global health policy making that the Trump administration has left. However, the EU is not, or were not, a very active part in global health policy making. And I would argue that they lack capacities and also experience, because usually it was global health policy making was very dominated by the UK, and the UK leaving the EU left also a vacuum in European global health policy making. So what I would like to say,
I would just want to explain something, because this is just from my basic knowledge of economics. Public good is not just a random thing that you feel good about saying, right? A public good has conditionalities to become a public good. Clean air is a public good. It's non-excludable or non-rivalrous. So if someone uses some, the rest of humanity doesn't have less of it. If I breathe clean air, others don't lose clean air, and so on. And you can't exclude people from having it. Those explicitly don't apply to vaccines that are produced, are limited in numbers, and so on. Was it just an oversight, or was it, because how could all those people with all their advisors and economists use a concept that badly that is meant to be precise?
Yeah, I wish I would have the answer for this. So technically, herd immunization is a global public good, but not the vaccine itself. The vaccine itself is a private good, as Ashal said, but the function that vaccinated population fulfills is then the public good. So I can't tell you who came up with this narrative, which was then very present and used and reused in the political field. So what I wanted to say is agenda setting with this narrative was far away from global health practice and the actors who usually do global health policy making, leaving them with a high agenda that is not in the system that we have, not achievable, aspirational, but not achievable because of the limits of the system we are in currently. And at the same time, because we were not prepared, being completely overwhelmed in high-income countries in fulfilling the role. Just to give you an example, in the first 3 months, the German policymakers here in the Ministry of Health, but also in the Foreign Office, they were basically busy with getting people, Germans from other countries, back to Germany. They were all busy with that, not really thinking of vaccinating the world. Another point I would like to make is that I think global health policy making and also thinking about vaccinating or providing vaccines to other countries starts here in Germany. So I looked at how do German politicians, the Minister of Health, for example, communicate to the German public when it comes to distribution of vaccines to other countries or to COVAX. And in the first year, there was no communication about it. COVAX was there and working, but publicly announcements towards COVID were very quiet. And it was basically the communication towards the German citizens: we vaccinate all of you. No language on we decided to first vaccinate all health workers worldwide, as recommended by World Health Organization. So Germany came up with its own prioritization, as all high-income countries did, ignoring all the other countries. For example, the German Ethics Council, which is a powerful body, in its first guidance didn't mention the word global, international, not even Europe. So they completely forgot about the world and only focused on German citizens, considering also that Germany had just an election this year. So we have to consider the politics and the national politics when we look at these issues. In my opinion, German politicians have not trusted the German citizens to really understand that in a pandemic, global thinking is necessary. I also believe that the majority of Germans would have understood that you first have to vaccinate all healthcare workers, including humanitarian actors worldwide, as recommended by WHO, as I just said, before you vaccinate healthy young people like me. And I think the majority of German citizens can understand this, and they were just not trusted. So I think we have to, the political landscape must be better considered by health professionals and also by humanitarian actors. Maybe I'll leave it here.
Thank you, Mike. We'll probably come to some of that, but I'll go back to Rachel. It's astonishing. One of the features here is that not that actually, the rich ended up with vaccines and the poor didn't. That's, as you mentioned about the pneumococcal vaccine, this happens all the time. It happened with the HIV/AIDS in the early stages, still happens. And it happens with almost everything that costs money. What's astonishing to me is even the pretense of solidarity crumbled after a while. And, it felt that stuck in the middle of their sense of we need to vaccinate our own citizens to win the next elections or to appear to be appropriately in our place, and doing this. There was not anymore any even pretense of we're going to do the appropriate thing of ending the pandemic globally by vaccinating people. This sort of failure, which takes a more amplified shape now, is it Achal, is it a bug in the global health system, or is it a feature of it? Is it that the global health system is really not supposed to succeed? Because one struggles to find an example of a sweeping success of global solidarity when it comes to health.
Yeah, this is such an interesting question, isn't it? And I'm sorry, the last time I was talking about COVAX, I almost went into a trance. I find COVAX endlessly fascinating, and I could possibly speak for hours on it. No one would want to hear that. To wrap that up, COVAX's rich history of entrenching existing inequities, doing small tweaks to a very, very privileged system of pharmaceutical production that they left untouched, was its history going into COVID. And Tamam, you talked about us being in the same boat and how that is hilarious. I disagree with you. I think we were in the same boat. It's just that that boat was the Titanic, and it had a first class and it had a second class, and it had steerage. And I think as the pandemic has progressed, we've realized who's where. It's very, very clear. COVAX itself has these tiers, right? For rich countries, for middle income countries, and poor countries. It's really just like the Titanic. No rich country wanted it. Few middle-income countries made any use of it because it just didn't have any vaccines to give anyone. And any poor country that actually depended upon COVAX as a lifeline in the last 1.5 years is sorely disappointed to have received the little trickle of between 1 and vaccines for 1 to 3% of their population. In terms of how much this was baked into the system, Tamam, I remember I grew up on the wrong side of the Cold War in India at a time when we were not aligned with Western Europe or the United States. And one of the phrases that was bandied around a lot when I was young is self-reliance. This idea that you had to make everything within the country yourself. South Africa, ironically, has a sort of imposed system of self-reliance, not because they were socialist or aligned with the USSR, which they were certainly not, but because of sanctions against South Africa starting in the 70s and escalating through the 80s. Many public industries in South Africa grew as sort of industries from within the country because they had to. I mean, they couldn't do anything else. I mean, they had to make their own things because no one would sell anything to them. For us, people were willing to sell, but we were a closed country. And so the idea was self-reliance, to be able to produce everything you can. Now, it's only countries of a certain size that can do that. India is, of course, of more than a certain size, so could. One of the legacies of that period of self-reliance that lasted roughly between independence in the late 1940s to a period of economic opening up in the 1990s is the pharmaceutical industry that we see today, that much of the poor world relies upon, sometimes without success, but nevertheless relies upon to a large extent. And I was so struck by some of the early indicators in this pandemic, which were health systems in Vietnam, for instance, which showed remarkable resilience to be able to keep a population healthy and involved simply because of decades of practice at doing the right thing, regardless of, let's say, donor demands or trends in global philanthropy, of which, unfortunately, an organization like Gavi was an integral part. Unfortunately, when it comes to self-reliance on medicines, the system of pharmaceutical monopolies that surround a vaccine, for instance, really make self-reliance impossible. Until 1996, countries had the sovereign ability to decide how to regulate monopolies themselves. They weren't beholden to a one-size-fits-all system. But ever since the creation of the World Trade Organization, we are beholden to this. There is no self-reliance. There cannot be self-reliance, rather, because there's hardly any sovereignty when it comes to managing medicine monopolies. And that's partly the reason we're in the mess that we're in. And so what's really interesting in the way that solidarity has worked, there's this word that gets bandied about in public health a lot in terms of regulation and policy setting, including in intellectual property, which are the monopolies that we're faced with now. It's harmonization, which is an interesting counterpoint to solidarity, because harmonization, when it comes to monopolies on medicines, often implies more countries just doing what the European Union and the United States would like. That is a kind of solidarity as well. One side of a nation, one nation is at one side of a gun and the other nation is at the other, but it's a kind of harmonization. The other kind of solidarity, which is sharing, which is cooperating, which is not working with the whole set of artificial economic restrictions that have just been created out of thin air and very recently, that we see so much less of. There is, to a certain extent, I think, a degree of astonishing solidarity between like-minded governments in Latin America, so Argentina, Cuba, and Mexico, for instance, and including Venezuela, do have a lot of really interesting cooperation. They use each other's regulatory systems to evaluate vaccines. They share vaccine technology, for instance. And it's really very interesting when it works as to the spirit that exists within those countries. But outside, on the one hand, you have philanthropic actors like Gavi included, but many, many others, who have simultaneously tried to take over parts of poor countries' public health systems in the name of philanthropy, weakening their own ability to do this themselves, but also in other ways actively attacked the concept of self-reliance, even of this idea of every island is a nation to itself, disallowing countries like India, who wanted to be a nation, an island unto themselves, from being able to do that through rigid international trade rules that, in fact, prohibit many of our own abilities to help ourselves.
Thank you, Achal. Now, just to put a point in, 20 minutes before we finish, I can almost hear people in our audience who come from a very traditional humanitarian intervention side rolling their eyes at the conversation that doesn't have an implication. My argument here is we are in a situation where we have two major humanitarian consequences to this global setting of anti-solidarity. One of them is we have tried to overcome the problem of self-reliance where it's absent before, Achal, by buying stuff in the West and shipping it to the South, whereby our own, doctors and nurses and so on are able to treat their patients. Now, that was an imperfect system, but at least it gave us the ability to say, you know what, when we take care of patients, we treat them properly, and manage to blind ourselves slightly to the situation where, there might be other patients 5 kilometers away who neither have the humanitarian health intervention nor the medicines that come with it. But today we're faced with a situation that is bigger, and I think HIV was one. And COVID is another of those examples where this, I deal with the circumstance that is around me, stops being a functional argument. The second concern, and where I think this level of conversation is absolutely important, is a situation whereby the humanitarian system, as well as the global health governance that is designed, that one that is designed to fail, but even the humanitarian system that is trying its best, become parts of enforcing the system itself, the system of inequality and crumbling of solidarity, because we keep doing things, we keep keeping things going. And the question I would like people to get out with, if this is the circumstance we're living in, if this is not just an accidental failure of the system because COVID is just too big and too, massive and too whatever it is, then what should be our position when we fail to treat our patients today and we risk enforcing a system of inequality that pretends to be a benevolent system? And from that angle, Marlies, you're looking at it from, that singular context, that where you still have the memories in South Africa of the failure 20 years ago and the failure that is ongoing today. You mentioned something of it. And can you tell me what could have been learned and hasn't been insistently? What is the thread that puts the two together?
Thanks, Simon. I think I'm going to share a couple of thoughts about inequity and inequality specifically and tie that back to the theme of this panel around decolonisation and vaccine nationalism, and get to your question from there. In the chat box, I've put a link to a political satirist in South Africa called Sapiro, and he uses the Christian parable of the 4 horsemen and he adds the monopoly man as the fifth horseman, that talks about hoarding and about corporate greed. And I think that illustrates some of the key concepts and some of the values. And I think what we have spoken about and thought about in this panel is perhaps the values of premising health and well-being above profitability and maximizing profits. And we've been grappling with some of the details and the implications of those. And I think this image illustrates that very well. I would like to put some details to inequality, and I want to talk about it in terms of global inequalities. And I think some of the statistics, and it might be that people are very aware of this, but putting a map of our world in data that talks about how we've been vaccinating the world, and you'll see that the African continent is very pale, and that less than 5% of the continent have been fully vaccinated, and that's in contrast to Germany, where 2/3 of the population is vaccinated, and some of the countries in Africa, former German colonies like Chad is at 0.2%, Nigeria at 1.1%, Cameroon at 0.5%, and how this illustrates some of the key concepts that some of us in this panel have been thinking about, especially around how our countries in the global north have bought vaccines, while the rest of the global south had to depend on COVAX, and the drip feed that comes from there. I think it also replicates some of the thinking around internal inequalities in countries like South Africa, where with our rollout, people with medical aid it was possible for them to access the vaccine a bit earlier. In South Africa, we don't have a system to vaccinate people who are not documented. So people who are homeless, people living in rural areas who might not be able to access documentation, people who are undocumented migrants, they can't access vaccines. And I think these are probably fault lines. Paul Farmer talks about existing fault lines in how diseases develop and play out and how they reinforce each other. I think these are what other countries could speak to as well. And I think many of these issues were very clearly illustrated 20 years ago with HIV and AIDS. These fault lines, the corporate greed, and how some of the solidarity that was shown there have been reactivated. I think especially in activist networks and academic circles, where some of the relationships forged and the principles that underlay those collaborations are alive and well, and that have promulgated some of the important resistance to the corporate greed in this context. But I think, as Mika has said, perhaps it's been a surprise that we would go down that route again, and that our global health architecture is not fit for purpose, and that those have to change.
Thank you, Marlies. Thank you. Now, you invoked part of our title, which is the colonialism, the coloniality of global health, and how that applies. And here's an interesting one, because there is both a resistance and an acceptance on different sides of that expression, on whether that does reflect one of them. And I want to just offer a couple of ideas, both for and against. Obviously, the global health system isn't like a colonial army, but there are many of the practices, including the deciding on behalf of people in other places what is best for them, the carrying of this philanthropic healing mission that allows organizations that are largely based in the North and led by people who are a product of the global North to make life and death decisions on behalf of other people with near complete impunity. I sit here in Geneva, and if you look at the map between Geneva and the east coast of the US, is almost all the money and all the decision making. Global Health 50/50 has put their report out, and the leadership of global health is almost all white men from the North. And those are the shadows of the continuing dominance of people. On a simple level, people who are never hungry decide who eats. People who are never sick decide who gets protected, and so on. But also, there's something that doesn't add up, and this is where I want to go to Mike, because one could argue, I would understand rich countries protecting their interests as a phenomenon, not as a moral position. But what they've done is paid an advance massive amount of money to vaccine manufacturers and didn't ask them for anything. So the taxpayers in the West, including German taxpayers, paid the billions for research beforehand and then paid for the vaccine again. Why would any rational actor, to use an ambiguous economic term, pay for a product twice when they can pay once? What's the interest of the governments of the global North in, entering insistently in a failed losing deal?
Yeah, thank you for the question. I'm very, very much wondering why we have so much anger against the big pharmaceutical companies, which is, of course, okay to have this anger, but not as much against our policymakers and the parliamentarians here, because in the end, they are responsible for making us pay twice. And not only the pharmaceutical companies. So we have protest before the vaccine company of BioNTech, but not in front of the German Bundestag on this topic so much. So I think the pressure needs to also go towards the parliamentarians. Let me reflect a little bit on Germany's role right now, maybe. I think because Germany's in a very ambivalent role, blocking the TRIPS waiver, completely mirroring the arguments from the pharmaceutical companies. Some of you may have seen our Minister Spahn at the Graduate Institute in Geneva. I think it was live streamed, completely mirroring the arguments that the pharmaceutical companies put out in the world, that for example, the TRIPS waiver wouldn't solve the problem. We don't have data that it wouldn't solve the problem. So they are basically getting the arguments just out there. And at the same time, so blocking the TRIPS waiver on the one hand, on the other hand, being one of the biggest donor to the World Health Organization, which leaves Germany very ambivalent, which will have, or which has already, how do you say, einen negativen Beigeschmack, a negative tone or a negative taste when it comes to Germany in total global health policy making. Of course, there are different actors. I don't want to justify or explain Germany's policy making, but there are different actors involved. So when the TRIPS waiver, it's rather the Ministry of Economics or the Ministry of Justice. And when it comes to WHO, it's the Ministry of Health. So it's a problem of incoherence here in Germany and of using a child's word of non-harmonization here in Germany when it comes to these positions. I think I would like to zoom out a little bit to see better the underlying structural challenges we are facing. I think what is visible right now, that the current global health governance and access to medicine system is broken, but still fits high-income countries. And I think as long as they profit economically or in protecting their people's health, they won't allow any changes. I think in the moment high-income countries starts to not profit anymore, then they would allow changes. So I think this leaves us with two big questions. One is, under which conditions would high-income countries change their behavior? Is it maybe pressure from NGOs or maybe also the humanitarian world? I think no, because in the past years, we had enough pressure and enough blaming and shaming. Maybe it's another condition. And I think what I observe here, it's rather geopolitical circumstances that may change political behavior in this instance. For example, the fear that low middle income countries will depend rather more on China or on Russia in the future. I mean, just to give you a scenario that is discussed here, imagine we have another wave and another variant of COVID-19, and the BioNTech Pfizer vaccine is not working anymore. But Sinopharm and other Chinese vaccines are working. I think, and I argue, this would change the system immediately. We would talk about the vaccine waiver here in Germany in a very different way, because then we need access to something we don't have. I think this is just to give you a scenario. And I think the other question is, how can low and low middle income countries come together to increase their power and leverages, for example, in the non-alignment movement or in regional institutions like the African or Asian Union, to really put something against this? And I mean, not in terms of money. Power can come in different kind of ways, and also considering other policy fields, not only health. What do they have to offer that they don't allow the high-income countries to get anymore? I would say and argue that usually health and health programs are used to, in a diplomatic kind of way, to make international relations and cooperation better or easier. But right now, even this is not possible anymore. So I think the vaccine apartheid, vaccine nationalism has long-lasting consequences on international relations, not only in the field of health, but also in others.
And to bring another shadow of previous colonialism, it is not new that health programming, international health, is used as one of the tools of continuing dominance and by implication spreading political interest. That is not to say, and here let's be clear, I think it's important to acknowledge that there are people who rely on international aid and health and the humanitarian sector, and regardless of the diagnosis, this is not a position that makes people lose their existing healthcare. It is a position that requires us to examine a few layers beneath what's obvious to our eyes. And here I will just say a couple of things and then give you kindly the last comment before we close. We have an immediate, like today's situation, and one that is a couple of decades away. The first one is Merck has just gotten or is about to get an emergency use for the pill, the molnupiravir, which is going to be effective direct acting agent on COVID-19. They want to sell it for $10, which is really, compared to other medicines. And Merck is playing all the cards because they were part of the HIV withholding medicines in South Africa 20 years ago. So they are trying to play nice and say that they will give it for cheaper to poorer countries. We don't know how or at what prices or so on. But before that even became possible, the US has bought a third of the whole possible production for the next year. So even if it's cheap, it's not going to be easily available. And this is a problem because many of the humanitarian actors and medical and health actors are not going to be able to treat patients that come to their door. We are going to fail to treat patients because of a system that we knew existed. And one of the questions, and when does it stop being possible to react only to what's happening after it's happened? The second thing is, in a certain way, a pandemic is simple. This is a single pathogen and potentially has a solution that works. If we're looking at what's a humanitarian crisis in 20 years, it's going to be the humanitarian consequences of climate change. It's going to be multi-layered, extremely complex, social, economic, political, and medical influences. There will be new diseases or diseases emerging and traveling to other places. And if we have a global health system and a humanitarian system that cannot hold itself within the pretense of solidarity under what is potentially a stress test for the climate change consequences. What are we going to do when people get displaced, when conflicts break out, and when hunger and disease become much more rampant? So in conclusion, I will kindly ask you for the sort of 1 minute, what would you tell humanitarian actors that are our audience today they should be considered in addition to their operational priorities if we are to survive this pandemic and future repercussions of it? I know too much to ask for a minute, but I'll go with Echal. Thank you.
Thank you. And I'll try to do this in just a minute. If I was to speak to humanitarian actors and say, to ask them to consider the state of the world, I'd point them to something that Marian Deckers, he was the CEO of Bayer, a company, a large pharmaceutical company, said in 2014. They had a drug called sorafenib, they called it Nexavar, a kidney liver cancer drug, very useful, too expensive in India. So India issued compulsory licenses, took over the monopoly. And he was asked about this at the Financial Times conference where he said, I don't understand it. It's theft. Look, we didn't make this drug for India. We made this drug for people who could afford to pay for it. And that one statement, I think, encapsulates everything about the state of the world we are in today in the pandemic, everything that goes from it. And I would urge us to consider what that statement means as a state of the world. It's been the same. He just was more honest than more others are. Thanks.
Thank you, Echal. Marlies, please.
I think my main message to the audience and humanitarian actors are around the short-term wins in the TRIPS waiver. I think activists, civil society need to be unequivocal about the need to stop blocking the waiver and to have that go through. We cannot have 10,000 people dying per day and the technology and the knowledge being available but not being shared. And I think that's short-term. Longer term, we need as much advocacy as we can and political will about investing in health, reprioritizing values around health and well-being, and challenging the value of maximizing profit. And we need international frameworks that support these values. And I will stop there.
Thank you very much, Marlies.
So usually I talk to policymakers and not so much to humanitarian actors. What I would say policymakers is solidarity is the best crisis prevention we can have and we can do. So we need to look more on solidarity, even though we know it's not very being implemented, but it's the best prevention we have. For humanitarian actors, I would say engage more in political science and create more political science capacity within your organization, even though I know it's difficult considering financial or lack of financials. But I think we need more advocacy that is directed to the political and commercial determinants on health. And maybe I'll leave it there. But even though I was so pessimistic, I think solidarity is something we need and should continue working on.
Thank you very, very much. I think we are a couple of minutes beyond our time, so I won't take much. But I find that we have heard today a few angles that are both a world away, but are also in the heart of the ability of humanitarian actors, not only to address COVID, but to access people in crisis and to be able to provide even the most basic things, both in the sense of not addressing COVID hinders everything else, but also that this is a sign of everything that lurks under the surface. And it is feasible, at least for a while, I believe, for us to continue to do what we do and surf under the wave of, exploitative way of doing business in global health and in global governance. But if COVID tells us something, is that we probably have a role, not alone, but with all those who are facing other sides of this coin, of where the system is not designed to serve the people that we care about. And there's navigating, doing what we do while not helping the system in its disservice to people we care about is an exercise in both in both knowing what's happening, deciding the position against it, and taking action. I hope this has